introducing Dr. Windreich this morning. Randy Windreich earned his BA degree from the University of Pennsylvania and medical degree from the Sackler School of Medicine. After completing his PEDS residency at Inova Fairfax Hospital for Children and Pediatric Hematology Oncology Fellowship at UPMC Children's Hospital, Pittsburgh, he joined the Division of Blood and Marrow Transplantation and Cellular Therapies at UPMC Children's Hospital, Pittsburgh as an attending physician in 2011. In his current role as Associate Professor of Pediatrics, as well as the Clinical Director and Fellowship Director in BMT-CT, Windreich remains dedicated to education and improving clinical care. He is also committed to the clinical research, both as primary investigator and collaborator for studies that investigate novel reduced toxicity and reduced intensity conditioning regimens for pediatric patients undergoing hematopoietic stem cell transplantation for acute leukemias, drug pharmacokinetics of agents used for chemotherapy, graft versus host disease, and antifungal prophylaxis and treatment, as well as alternative uses for hematopoietic stem cells. Please welcome Dr. Windreich this morning for Grand Rounds.
Thanks so much for inviting me, Jimmy, and thank you, Noel, and the rest of the chiefs. Let me get everything set up here to share my screen. Give me a quick sec. All right, so hopefully you guys can see me and hear me. So today I'll be presenting about reduced intensity transplants for leukemias in children. Just before I begin, a couple of disclosures. I serve on the Strategic Council for Mesoblast and as a consultant for Jazz Pharmaceuticals. Neither of these are relevant to today's presentation. What I hope you all gain from today is an appreciation of the history of hematopoietic stem cell transplantation and to familiarize yourself with this role in childhood leukemia. I would also like you to recognize variations in conditioning regimen intensities, as well as understand the reliance on graft versus leukemia or GVL effect in reduced intensity conditioning strategies. And then lastly, to review the available medical literature assessing the impact of reduced intensity conditioning regimens on transplant for pediatric leukemias. So
hey,
before
Randy,
I dive in, oh,
sorry,
yes.
Sorry to interrupt. We don't see your screen.
Oh, let's see. Sorry about that. All right, is that better?
Yep.
All right, perfect. So before I dive into transplant, I just want to give a brief overview about childhood cancer. It is the second leading cause of death in kids behind accidents, and each year the parents of approximately 15,300 children will hear the words, "Your child has cancer." That comes out to about 43 kids diagnosed with cancer every day. Childhood cancer affects all ethnic, gender, and socioeconomic groups, and the average age of diagnosis is around 6 years. 12% of children diagnosed with cancer do not survive, but even though 1 out of 8 kids will not live, there have been really major treatment advances in recent decades, leading to more than 80% of children with cancer now surviving 5 years or more. And overall, this is a huge increase since the mid-1970s, when the 5-year survival rate was about 58%. Before we dive into leukemias, it's just very important to know about cancer in general, that every malignant cell has a normal counterpart. So when we're referring to normal hematopoiesis, if there's a disruption in the lymphoid stem cell development, that will result in acute lymphoblastic leukemia. And when there's disruption in the myeloid stem cell development and differentiation, whether that's in the red blood cells, platelets, eosinophils, neutrophils, monocytes, basophils, this will result in acute myeloid leukemia. So for a brief overview of acute lymphoblastic leukemia, this is the most common cancer that we see in children, with about 3,100 new cases diagnosed in the United States each year. The peak age, as you can see, is between 2 and 3. So this affects primarily younger kids, but it can really affect any age group. ALL makes up about 1/4 of childhood cancers, and ALL specifically makes up about 3/4 of childhood leukemias. Treatment typically consists of 7 to 8 months of more intense chemotherapy, followed by a lower intensity maintenance phase for a total duration of approximately 2.5 years. The large majority of kids are able to achieve remission, with about 85% of them now cured of their disease. For those who are not as fortunate to be cured in first remission, the strongest predictors for how patients will fare after relapse depends on the duration of first remission and the site of relapse. Those who tend to relapse earlier tend to fare worse and have worse outcomes, and those who relapse in the bone marrow or in the bone marrow combined with either with an extramedullary site also tend to have more aggressive disease. So what can we do for patients in this situation? Typically reinduction chemotherapy to try to reinduce a remission. And following that, depending on their relapse story, either further chemotherapy, immunotherapy, which is a treatment strategy by activating or suppressing the immune system. This can be done either through the use of monoclonal antibodies, such as blinatumomab or inotuzumab, or through chimeric antigen receptor or CAR T-cell therapy. I believe Erica Freeling spoke about this last year in the grand rounds. And then another treatment strategy would include stem cell transplant for relapsed leukemia. Disease-free survival for myeloablative transplants for leukemia in second remission is about 30 to 40%, though some studies actually report as high as 70% cure rates. Though in common with most transplant studies, treatment failure is typically a result of treatment-related mortality and disease relapse. Moving on to an overview of AML, this accounts for about 20% of childhood leukemias. So there are approximately 500 new cases each year in the United States. The risk stratification is not as well defined as for ALL, but primarily relies on cytogenetics and molecular findings of the leukemia and then disease response, specifically minimal residual disease or MRD testing. Treatment for AML typically consists of about 6 months of intensive inpatient chemotherapy and 85 to 90% achieve remission, with approximately 65 to 70% of patients cured of their disease. And improvements in event-free and overall survival with AML have resulted because of excellent supportive care, adaptation of therapy on the basis of each patient's response, and the use of intensive chemotherapy or transplant. Now, what we know about transplant in acute leukemia, so the use of transplant in first remission has been under investigation since the late 1970s. Prospective trials of transplantation in children with AML suggest that overall, 60 to 70% of kids with HLA-matched donors available who undergo allogeneic transplant during their first remission experience long-term remissions, with the caveat that outcome after transplant is dependent on risk classification status. Now, the benefits of transplant would be delivery of a leukemia-free graft and production of strong graft versus leukemia effect. Now, this is balanced with risks of transplant, including transplant-related mortality and long-term transplant-related morbidity. Transplant is generally recommended after achieving a second complete remission, with survival benefit shown in about 40% of children in their second complete remission. This is in comparison to less than 10% who are treated with chemotherapy alone. Even for those who relapse after the first transplant, you can still salvage them with the second transplant. Those who tend to fare better include patients experiencing a later relapse, so those who relapse at least 6 to 12 months from the first transplant, those who enter in the second transplant in complete remission, and if possible and if safe, use of a second myeloablative regimen, although this is not always feasible. The other patient population with AML that we know could benefit from transplant are those with refractory disease. Studies have shown a better event-free survival with transplant over chemotherapy, and one of the big prognostic factors would be morphologic complete remission, showing a really impressive survival benefit over those in not complete remission. However, there are still unknowns with transplant in AML. For starters, the timing. Who would benefit in first complete remission versus second complete remission, or would it only really be for relapse and refractory disease? Also known is the optimal conditioning regimen. Do we need radiation? Can we get by with just chemotherapy alone? There are actually no data that total body irradiation is superior to a busulfan-based myeloablative regimen, and actually a large prospective cohort through the CWMTR, which I'll get back to in a sec, of children and adults with AML, MDS, and CML, chronic myeloid leukemia, showed superior survival of patients with early stage disease with a busulfan-based regimen compared to TBI. Another unknown is the best donor cell source. related donors, unrelated donors, or even alternative donors options such as haploidentical transplants. And really, aside from matched sibling and matched unrelated donors, haploidentical transplants and natural killer cell transplants have been studied in AML. In spite of good data, though, of haplotransplants in adults, there's less evidence for its role in pediatric AML, and therefore it's still considered experimental. And then really the last unknown is conditioning intensity, and this is really the major bulk of this presentation, myeloablative versus reduced intensity. Before I dive into transplant with leukemia, I just want to really step back and talk about transplant in general. I really enjoy just history to start with, and I like to include the history of whatever topic I'm presenting in my talks. So I'll have a few slides here about just the history of hematopoietic stem cell transplant. So this all started with early animal studies by which bone marrow was found to be the most sensitive organ to the damaging effects of radiation. Scientists found, though, that reinfusion of marrow cells was subsequently used to rescue lethally irradiated animals. A little over 80 years ago was the first report of infusion of bone marrow to restore hematopoiesis. This was a patient with aplastic anemia who was treated with regular transfusions, as well as infusions of small aliquots of his brother's bone marrow. About 10 years later, in the late 40s and early 50s, Jacobson and colleagues shielded the spleen from radiation, allowing mice receiving lethal doses of radiation to recover normal hematopoiesis. And ultimately, such experiments made it clear that hematopoietic reconstitution of irradiated animals originated from elements in the bone marrow or the spleen. Then in 1957, E. Donald Thomas, who I think is considered really the forefather of transplant in the United States, made the first attempt at human transplant. Throughout the 1950s and 1960s, there were approximately 200 allogeneic bone marrow transplants performed in humans with no long-term successes. These first experiments were performed in patients with advanced hematologic malignancies, so various leukemias and some lymphomas even, and demonstrated that chemotherapy followed by IV marrow infusion could result in a transient graft, although all patients subsequently died of progressive disease. In 1959, lethal doses of total body irradiation and bone marrow from an identical twin were used to transplant 2 patients with advanced leukemia. Hematopoiesis was established within weeks, but again, both patients ultimately relapsed and died. In 1963, Georges Mattei from France reported the first case of complete engraftment with survival beyond 1 year. This patient developed what is now known as acute and chronic graft-versus-host disease and died, granted free of leukemia, but 20 months later of varicella encephalitis. So not until 1968 were the first successful allogeneic transplants, and these were 3 patients with congenital immune deficiencies. I believe Westcott-Aldrich and SCID were the diagnoses for the 3 patients. Mattei also published his experience with 21 patients, not as successful as the first reports of those 3 patients, with everyone ultimately dying either of graft failure, leukemia, or graft-versus-host disease. In 1977, Thomas and the Seattle group report the results of 100 patients who received an HLA-identical sibling bone marrow transplant for refractory leukemia. Now, this was a landmark paper because 13 out of 100 of them became long-term survivors. Now, in this day and age, we think 13%, that's terrible. But at the time, this was really a groundbreaking event, ultimately leading to Dr. Thomas receiving the Nobel Prize in Medicine in 1990 for his development of bone marrow transplantation. So this brings us into sort of the modern day, the 1980s. We've moved from bone marrow to peripheral blood stem cells being used for the first time as a stem cell source. In 1988 was the first successful umbilical cord blood transplant for a young boy with Fanconi anemia, using the cord blood collected at the birth of his sibling. And 1992 is not only known as the USA Basketball Dream Team Olympic victory, but also the first successful umbilical cord blood transplant for leukemia. And really since then, transplant has become an accepted treatment for a wide variety of diseases. This includes various malignancies such as ALL, AML, CML, JMML, myelodysplastic syndrome, lymphomas, including Hodgkin's and non-Hodgkin's, and various solid tumors like neuroblastoma, brain tumors, germ cell tumors, Ewing sarcoma, Wilms tumors, also bone marrow failure syndromes such as aplastic anemia, Diamond-Blackfan, Fanconi anemia, immune deficiency disorders such as SCID, Westcott-Aldrich, and AIDS in adults, congenital hematologic defects such as sickle cell disease and thalassemia, metabolic storage diseases such as leukodystrophies like Krabbe disease, metachromatic leukodystrophy, adrenal leukodystrophy, mucopolysaccharidosis like Hunter syndrome and Hurler syndrome, various autoimmune disorders such as Crohn's disease, scleroderma, JRA, or I guess now known as JIA, lupus, and even multiple sclerosis. And then miscellaneous disorders such as osteopetrosis in infants and amyloidosis in adults. Now, some of the limitations and risks associated with allogeneic transplant include lack of naturally match-related donor, regimen-related toxicities, graft failure or graft rejection, graft versus host disease, and opportunistic infections, with the latter three increased in frequency and or severity after transplant from unrelated donors. I mentioned HLA here, and just a brief word about what HLA means. So it stands for human leukocyte antigen, and these are proteins found in the membranes of nearly every cell in the body, but especially in high concentration on the surface of white blood cells. The HLA loci are part of the genetic region known as the major histocompatibility complex found on the short arm of chromosome 6. And really, any cell displaying some other HLA type is viewed as non-self and is seen as an invader by the body's immune system, whether this is some infectious process or, in our case, cancer cells, which can then result in rejection of the tissue bearing those cells. Matching for HLA decreases the probability of graft versus host disease, by which donor T cells recognize host tissue as foreign, evoke an immune response on the recipient, and result in recipient tissue damage. HLA matching also decreases the probability of graft rejection, which is sort of the opposite direction, whereas recipient T cells examine the donor cells, recognize those as non-self, evoke an immune response, and rejection will occur. And then lastly, transplant-related mortality. Now, only about a quarter of patients will have a matched family donor. This leaves the other 3/4 of patients receiving unrelated donor stem cell products. And these can be found through really a large number of national and international registries. In the United States, we primarily use the National Marrow Donor Program, or NMDP. And a quick plug for anyone who might be interested in joining the registry as a donor, you can just go to bethematch.org, sign up online. They'll send you a kit in the mail. You just do a quick buccal swab, send it back in a postage paid envelope. And the turnaround time is about 2 months before you end up in the NMDP registry. So we're always looking for more and more donors. One of the big international registries is the BMDW, or Bone Marrow Donors Worldwide, that contains over 39.5 million donors throughout the world. Most of these are bone marrow or peripheral blood stem cell donors, and then over 800,000 cord blood units. And this data is current as of the beginning of this week. This has allowed us to really find donors for just about everyone. We used to have trouble, and we as in the transplant community used to have trouble with the donors of certain races or ethnicities, just because there aren't as many of the same races and ethnicities in these registries. But as we've expanded our donor pool, looking at more unrelated donors, mismatched donors, we've been able to find matches for just about everyone of every race, of every ethnicity and gender. Now, this has made us, though, need to prepare these patients a little bit differently, though, coming to transplant. So we've had to adjust our conditioning regimens depending on the patient and the donor and the recipient through the use of various conditioning regimens. So the conditioning regimen typically lasts 7 to 10 days, but can range anywhere from 2 days to 3 or more weeks. This allows the delivery of chemotherapy, radiation, or both, and the goals really depend on what the underlying disease is. It can be to eliminate whatever malignancy the patient or the recipient has, to prevent rejection of new stem cells, and or to create space for the new cells. We're really trying to achieve these goals with minimal toxicity. So how do we choose what we choose? There are so many different chemotherapy agents out there, and radiation, serotherapy. So we use the patient's underlying condition, their disease status. Are they in remission? Do they have active disease? Their comorbidities. Do they have any organ dysfunction? Do they have any active infections? What's their performance status? And what's their risk of rejection? Some disorders have higher risk of rejection compared to others. So we want to make sure that we might be a little bit heavier on the immunoablation than some other disorders. Now, preparative regimens have variable intensity, toxicity, and dependence upon a graft versus tumor effect. Preparative regimens, as you can see here for transplant, have been termed either myeloablative, reduced intensity, and non-myeloablative. While full agreement has not been achieved, generally accepted definitions of these three types of regimens are as follows. Starting with myeloablative conditioning, this typically uses a single agent or a combination of agents expected to destroy the hematopoietic cells in the bone marrow. This essentially kills all residual cancer cells in transplant, or at least that's the goal. This also can cause immunosuppression for engraftment in allogeneic transplant and result in profound pancytopenia within 1 to 3 weeks from the time of administration. This resulting pancytopenia is usually long-lasting, usually irreversible, and in most instances fatal unless hematopoiesis is restored by infusion of hematopoietic stem cells. Non-myeloablative regimens use chemotherapy and or radiation doses substantially lower than those of myeloablative regimens. These tend to be more immunosuppressive, but not necessarily myeloablative. Reduced intensity conditioning it's an intermediate category. These regimens can cause cytopenias and but still require hematopoietic stem cell support. And the concept of reduced intensity conditioning is to deliver adequate immune suppression so that there's successful engraftment of donor hematopoietic cells with manageable graft versus host disease and the eventual development of a potent graft versus tumor effect. With this goal in mind, many immunosuppressive strategies have been incorporated into various reduced intensity conditioning regimens and studied, but no particular regimen has emerged as the optimal one. And the concept of allogeneic transplant as a treatment option for hematologic malignancies has long been based on the assumption that myeloablative doses of cytotoxic therapy were required for both disease eradication and host immunosuppression. However, over the last 15 to 20 years, there's been a paradigm shift towards curative potential of graft versus leukemia, or more generally speaking, graft versus tumor effect. The impact of graft versus leukemia effect has been strengthened by several observations, including one, decreased relapse rates in the recipients of allogeneic transplant compared with autologous or syngeneic transplants. 2, increased risk of relapse after T-cell depleted compared with unmodified grafts. 3, decreased risk of relapse in patients who develop acute or chronic graft versus host disease. And 4, remission induction after donor lymphocyte infusion in some patients whose disease had relapsed after transplant. These observations, in addition to better ways of controlling both host and donor immune reactions, led to reassessment strategies for allogeneic transplants. And specifically, instead of eradicating tumors through intensive and thereby toxic chemoradiation, the transplant donor's immune cells might be used for that purpose, relying on allogeneic graft versus tumor effects. So the goal of reduced intensity conditioning transplant is to harness that graft versus leukemia effect while minimizing toxicities and the risk of graft versus host disease. However, this is a delicate balance, as a number of prior studies have shown a lower risk of relapse in acute myeloid leukemia patients who experience chronic GVHD after reduced intensity conditioning, compared with those patients who did not, while some other studies failed to find such an association. Other advantages of reduced intensity conditioning regimens include they're better tolerated, they cause less tissue damage compared to myeloablative conditioning, they're actually cost effective due to leading to shorter hospital stays, and there have even been roles for outpatient administration. And then fewer long-term effects on fertility, organ function, secondary malignancies, growth, and development. I know this is a very busy slide, so I'll try to break it down. Before I dive into this one, I just want to give a quick word about the CIBMTR, which I'll probably mention a few times in this lecture. So the CIBMTR is the Center for International Blood and Marrow Transplant Research. This is a voluntary working group of over 450 transplant centers worldwide that contribute detailed data on allogeneic and autologous transplants to a statistical center at the Medical College of Wisconsin in Milwaukee, and the National Marrow Donor Program Coordinating Center in Minneapolis. And the clinical consequences of GVHD might not always be accompanied by sufficiently potent GVL effects to prove disease control and survival in patients. So as much as we always think and say that GVHD and GVL are inherently linked, that's not always necessarily the case. Now, an analysis from the CIBMTR analyzed the impact of GVHD in a cohort of patients with AML and MDS given various graft types after reduced intensity conditioning. In a landmark analysis of 630 patients at 1 year after a transplant, relapse incidence was reduced only in the group of patients who had prior both acute and chronic graft versus host disease, while acute or chronic graft versus host disease had no significant impact on disease-free survival. Beyond 1 year, however, we observed further divergence beyond graft versus host disease and graft versus leukemia with myeloablative and reduced intensity conditioning regimens. And that's what a lot of these graphs here are showing. After myeloablative conditioning, we observed substantially higher late transplant early mortality, or TRM, risk with any GVHD, and that can be seen in B, but no greater protection against relapse as seen in A, suggesting that any graft versus leukemia effects had already been manifested in the first year. GVHD therefore led to a substantially higher risk of late treatment failure. In contrast, among patients who had received reduced intensity conditioning regimens, 1-year disease-free survivors with both acute and chronic graft versus host disease continued to have a significant graft versus leukemia benefit, as shown in graph G, suggesting an ongoing active anti-leukemia process. The increase in late TRM associated with graft versus host disease was restricted to patients with both acute and chronic GVHD, as seen in F, and although statistically significant, was of a lesser magnitude in the cohort receiving reduced intensity versus myeloablative, so comparing F and B. Consequently, there was no higher risk of late treatment failure associated with any GVHD in patients receiving reduced intensity regimens. These data suggest that after reduced intensity conditioning, a setting where late GVHD-associated mortality is generally ameliorated, its potent association with graft versus leukemia effect might improve outcomes and increase the fraction of patients with leukemia who are surviving disease-free. So diving right into reduced intensity transplant in children, I want to first present the results of a phase 2 trial of reduced intensity transplants by the Pediatric Blood and Marrow Transplant Consortium, the PBMTC. This study concluded that favorable outcomes could be achieved for children and adolescents with hematologic malignancies in remission at transplant. Now, although the trial used a uniform transplant conditioning regimen consisting of busulfan, fludarabine, and anti-thymocyte coagulin, patients with a variety of hematologic malignancies were eligible. There was a lot of variability in stem cell sources, and enrollment was limited to 47 patients, so a fairly small study. And really just overall very heterogeneous. And this has really been the problem with a lot of these studies looking at reduced intensity transplants in kids. They're usually combined together with various other cancer types. So finding literature with just ALL, just AML, really is lacking. So turning to the adult literature, there are very few data available analyzing reduced intensity conditioning for patients with ALL just in general. And that's because ALL encompasses a group of what's thought to be in adults a chemosensitive disease, which raises concerns that reduction of the intensity of the preparative regimen before a transplant may have a negative impact on long-term leukemia control. So this analysis from the European Blood and Marrow Transplant group showed, as you can see here with the graphs, that reduced intensity conditioning regimens may reduce non-relapse mortality, but with higher risk of disease relapse and no statistically significant impact on leukemia-free survival compared to myeloablative conditioning. And just in case it doesn't show up well, the solid line is the myeloablative, and then the dotted lines are the reduced intensity curves. So really, in other words, there's an apparent trade-off here, including lower non-relapse mortality with reduced intensity conditioning, but higher rates of relapse. So it's also notable that the RIC patients did not do all that much worse than the myeloablative conditioning of transplants, although leukemia-free survival tended to be lower. However, overall survival, which is likely the most important outcome for an individual patient, was strictly comparable between both groups, as you can see here on the right. This is analysis of registry data from our neighbors to the north, the Canadian transplant community, that showed that reduced intensity conditioning was actually associated with an inferior overall survival compared to myeloablative conditioning. And then primarily US data from the CWMTR showed actually promising overall survival and an acceptable non-relapse mortality using reduced intensity in older patients with ALL, with improved outcomes seen especially in those transplanted in first complete remission and with good performance status associated. So really between these two slides, I've shown 3 separate groups with very different results, either no difference, worse outcome, or better outcome, or at least promising. So what do we have in pediatrics? Even more limited reports on the effectiveness of reduced intensity conditioning. Now, transplant outcome data after various RIC regimens for ALL are few and, with rare exceptions, or limited to those reports in adults. Thus, the effectiveness of reduced intensity conditioning regimens for pediatric ALL has not been extensively reported. These graphs here show a CIBMTR analysis of 38 pediatric patients with ALL who received reduced intensity conditioning transplants as their first transplant between 1995 and 2005, so over a 10-year period. The authors found that reduced intensity conditioning regimens were associated with myelosuppression in all patients, along with high rates of transplant-related mortality, acute graft-versus-host disease, and chronic graft-versus-host disease. Similarly, leukemia recurrence was also pretty high, resulting in only modest disease-free survival rates at 3 years. In general, though, enthusiasm for using reduced intensity conditioning for ALL has been appropriately guarded because of the poor responsiveness to post-transplant immune-based approaches in ALL, including rapid taper of immune suppression and donor lymphocyte infusions, or DLI, following relapse. So ALL hasn't caught on as well with reduced intensity compared to myeloablative, as really the main message here. Turning our attention to AML. Now, transplant from a suitably HLA-matched related or unrelated donor is the treatment option with the highest chance of prolonged survival with disease control for many patients with AML. The frequency of transplant has increased progressively, in part related to wider donor availability and in the introduction of reduced intensity regimens intended for older and less fit patients. Several retrospective studies have reported a higher risk for relapse and lower non-relapse mortality, but similar overall survival with reduced intensity compared with myeloablative regimens in adults. But because of the lower rates of toxicity associated with reduced intensity, these regimens are increasingly being offered to young and fit adults with AML. Now, a recent summary of the European experience that compared myeloablative and reduced intensity conditioning regimens for unrelated donor transplants for adults, as you can see here on the left side, concluded that reduced intensity regimens were associated with a higher relapse risk in patients less than 50 years of age and lower non-relapse mortality in patients greater than 50 years of age. So the overall results was a leukemia-free survival that was pretty similar in both conditioning regimens, regardless of age. A North American study from the CIBMTR showed similar results. Now, the impact of conditioning intensity on outcomes of haploidentical transplants for adult patients has been studied through the European Registry. Through a retrospective registry-based analysis, this was done by the Acute Leukemia Working Party of the EBMT, of over 900 patients, 900 adult patients with AML undergoing haploidentical transplant with either myeloablative or reduced intensity conditioning. And their conclusion was essentially no difference found between the two preps. Now, what they did find was that the major predictor of transplant outcome was the type of graft-versus-host disease prophylaxis used, their disease status, and their, probably more importantly, the performance status. Now, moving on to pediatric AML. Now, transplant from an HLA-matched sibling has generally been considered to be the treatment of choice for children with AML in first complete remission. However, with improved results now obtained with chemotherapy alone, and the known short and long-term risk of allogeneic transplant, this treatment option is no longer offered to all kids with AML in first remission, but is reserved for those with high-risk disease. In a CIBMTR retrospective analysis of pediatric AML patients receiving their first transplant over a 10-year period between 2000 and 2009, you can see the various conditioning regimens that they've used here. Now, the authors showed that relapse rates were not higher after reduced intensity conditioning compared with myeloablative conditioning regimens, and that myeloablative conditioning was not associated with higher transplant-related mortality compared with the RIC regimens. Whereas myeloablative regimens are currently considered the standard of care for allogeneic transplants in children and adolescents with AML. This study, albeit in a carefully controlled and non-randomized analysis of a modest number of patients, suggests that both transplant conditioning strategies are acceptable. Now, what we don't know, and this is one of the limitations of the study, is why these patients received reduced intensity conditioning regimens in the first place. When RIC regimens were introduced over 15 to 20 years ago, studies demonstrated less peri-transplant mortality and morbidity with these regimens, allowing for transplantation in older and sicker patients. Some studies in some studies in adults have confirmed higher relapse rates with reduced intensity regimens, but lower transplant-related mortality that offsets this disadvantage. In kids, on the other hand, TRM or transplant-related mortality is generally lower after transplant anyway, potentially reducing the advantage of a RIC regimen. Should relapse rates be higher with this approach? But in this study, the authors saw no increase in relapse rates with use of reduced intensity conditioning regimens and no change in rates of transplant-related mortality, perhaps reflecting the already low TRM that's seen with myeloablative conditioning in this population. So basically not seeing any major difference in relapse rates or leukemia-free survival, this opens the door for the potential of using reduced intensity conditioning in pediatric AML. And this ultimately led to our own institutional trial investigating myeloablative and reduced intensity conditioning transplants for AML and MDS. The study is registered on clinicaltrials.gov with the number seen here. What we've done is a single center prospective non-randomized dual arm phase 2 study involving pediatric patients undergoing allogeneic transplant for AML or myelodysplastic syndrome since July of 2016. So we've now been accruing a little over 5 years. The primary objective is to determine safety and preliminary efficacy of achieving acceptable rates of event-free survival at 6 months in pediatric patients receiving either a myeloablative or a reduced intensity conditioning regimen. And the conditioning regimen was chosen primarily based on organ function criteria. While the myeloablative conditioning regimen is the default, eligibility for the reduced intensity conditioning is assessed for patients who do not meet those organ function requirements for the myeloablative arm. Additional exclusion criteria for myeloablative conditioning include prior autologous or allogeneic transplant within 3 months prior to the start of conditioning, and patients with inherited bone marrow failure syndrome. So this protocol tested 3 hypotheses. First, that myeloablative conditioning, that our myeloablative conditioning regimen would provide improved rates of event-free and overall survival, that our reduced intensity conditioning regimen will be well tolerated and allow pediatric patients with significant comorbidities that would otherwise preclude them from transplantation to receive a potentially life-saving allogeneic transplant. And then lastly, similar to its actions on normal hematopoietic stem cells, incorporating GCSF or nucleogen or granulocyte colony stimulating factor prior to transplant may disrupt the interaction of leukemic stem cells with the marrow microenvironment, thereby sensitizing these cells to genotoxic stresses. So essentially, nucleogen can serve 2 purposes here. Number 1 is pushing cells that are in the G0 phase, in the rest phase of the growth cycle, into the G1, since cells that are in the growth cycle are more sensitive to the chemotherapy. GCSF also cuts the anchor of stem cells from the bone marrow, which allows them to then enter into the peripheral blood and thereby make them available or accessible by the chemotherapy, also helping trying to optimize the potency of the chemotherapy that we're using. The 2 regimens, sorry if this shows up too small for you guys, but the myeloablative conditioning regimen consists primarily of FOLFIRINOX, fludarabine, and busulfan, with busulfan dosing aiming for steady state concentration of 800 to 900 milligrams per milliliter. We also add alemtuzumab or Campath for those CD52 positive malignancies and those with mismatched grafts. And you can see here that nucleogen is incorporated on days -5, -4, and -3 prior to transplant. Then stem cell infusion on day 0. Our reduced intensity conditioning regimen on this protocol is fairly similar to our RIC regimen that we use for some of our other disease types here. We start with a low dose of alemtuzumab, along with 9 days of hydroxyurea. This is sort of like driving with your foot on the brakes and on the gas. Hydroxyurea helps push cells into that growth phase as well, and out the bone marrow, where they'll be available for destruction by the rest of the chemotherapy, including fludarabine for 5 days, melphalan and FOLFIRINOX, and once again, the nucleogen right here in days -6, -5, and -4, leading up to transplant day on day 0. So far we've accrued 20 patients. There was one other patient who was a screen failure who unfortunately progressed in his leukemia after consenting before coming to transplant. The median age of our patients is a little over 12 years, but ranges from about 9 or 10 months to close to 19 years of age. There's a slight preponderance of males over females. Most of the patients enrolled in the trial have or had AML, with most of them in first complete remission, and then 4 in second complete remission, so these were relapses, Then we had one patient come in with an M2 marrow, and M2 means between 5 and 25% blasts. The remaining 5 patients had MDS. And I'm realizing right now my math is off, so I believe we have 15 with AML and only 5 with MDS, so sorry about that. Sorry, 6 with MDS, I can't add. So half of those had an M1 marrow, so less than 5% blasts, and the other half had an M2 marrow. The majority of patients received a myeloablative regimen, which again was our default, only 2 of whom receiving Campath or alemtuzumab, and these were because of mismatched grafts, and then the other 5 receiving reduced intensity conditioning. Of those 5, 3 were because of cardiac dysfunction, 1 due to pulmonary disease, and the last was at the discretion of the primary attending, which in this case was me, because it was a second transplant. I'm just worried about toxicity with another myeloablative regimen so soon after his first. The stem cell sources are, as you can see here, with 30% receiving sibling bone marrow, 40% receiving unrelated cord blood, and then the rest receiving unrelated bone marrow or unrelated peripheral blood. We were able to find complete matches for a little more than half of our patients, although well matches or good matches in the others. On the right side of the screen, you can see the matches and mismatches in terms of gender, blood type, CMV status, EBV status, and then lastly, the cell dose with the median total nucleated cells per kilo, median CD34 cells per kilo, and then the median CD3 cells per kilo here. So our median day of neutrophil engraftment is 13 days with a range of 9 to 24 days. I would say in general, this is fairly good. The shorter the neutrophil engraftment day, the sooner your mucositis heals and the lower infection risk. Platelet engraftment tended to occur on a median of 33 days with a range of 18 to 50. More importantly, we had no patients experiencing graft failure. Our median length of stay, and this will make, I think, hospital administration very happy, is only 30 days from transplant day. So really the majority of our kids were able to get out around 1 month after transplant. One child as quickly as 16 days, and then one straggler as long as 51 months due to some complications. Our follow-up period is close to 3 years now, and ranges from 2 months up to almost 5 years with our longest patient. 6 month survival is at 94%, so 16 out of 17. We have 3 patients currently less than 6 months post-transplant, so we'll update this data in a few months. And then 3 of the 18 have experienced a relapse, so a relapse rate of about 16.7%. We saw acute GVHD in half of our patients on this regimen, moderate GVHD in only a quarter of the patients, and no cases of severe graft-versus-host disease. The moderate GVHD was a combination of skin and gut. We also saw mild chronic GVHD in about a quarter of the patients and severe GVHD in 1 of the 15 patients. All of these patients are still alive. Other post-transplant complications that we saw in our patient population, 4 patients who had no infections whatsoever, then of the remaining 16, we saw 12 bacterial infections, not 12 patients, but 12 bacterial infections amongst those 16, 15 viral infections, and some of these were just viremia without end organ disease, 1 fungal infection, and 1 other. We also saw veno-occlusive disease in 7 patients, and then 1 patient did later develop a blood clot. Our immunoconstitution studies are, as you can see here, with the blue bar graph being the CD3 count, so the total T cells, orange being the CD4, the T helper cells, and then CD19 or the gray bar graphs being our B cell counts. So seeing some nice immune recovery over the course of the year. We have had to adjust our graft choices and graft handling since the COVID-19 pandemic because of some mandates and recommendations coming from the National Marrow Donor Program. Primarily recommending and at one point requiring cryopreservation of grafts prior to start conditioning therapy. Since peripheral blood cells tend to cryopreserve better than bone marrow, we shifted our stem cell source to start including more peripheral blood stem cells. But in order to mitigate some of those, or some of that increased risk for graft-versus-host disease seen with peripheral blood stem cell grafts, we started doing more T cell depletion, with most of those patients undergoing CD34 selection with a T cell add back. So I think that will explain some of the slow recovery for some of our patients. We also see an impact of this in our T cell chimerism. So chimerism is essentially your percentage of donor cells in your whole blood and your T cells here in this first slide, and on the next slide, the myeloid compartment and the bone marrow. So ideally, we want as much blue here as possible. We want all of our patients to have either all or close to all donor cells, but I think we're happy with blue and orange here, so over 90% donor. What we don't like to see are the green and dark blue colors, and not so thrilled with the yellow either. And as I mentioned 2 minutes ago, that because of the T cell depletion that we had to start doing in response to the COVID pandemic, we were seeing some mixed T cell chimerism earlier on. That did seem, for the most part, to improve with time and with donor lymphocyte infusions. Now, with AML and MDS being a myeloid malignancy, the myeloid chimerism is very important then in this case, and we've been able to achieve total or near total donor chimerism in almost all of the patients, and we see this as well in the bone marrow chimerism. So really, conclusions so far from our protocol, or the highlights at least. One is that no graft failure occurred. Number two, no patients developed severe or grade 3 to 4 acute graft-versus-host disease. We did see, though, a little more than a third of patients developed severe veno-occlusive disease, which prompted us to begin defibrotide prophylaxis in some of our what we would deem as high-risk patients. We had no mortality, though, as a result of VOD on this protocol. So with a median follow-up now of over 2.5 years, we've had 2 patients relapse, but who are still alive. And as a whole, 18 out of 20 patients are still alive, with 1 death due to pre-existing invasive fungal infection and 1 death due to respiratory failure. So in our single institution study, both myeloablative and reduced intensity conditioning regimens demonstrate safety and efficacy with low rates of relapse, mortality, and acute and chronic graft-versus-host disease. And these regimens may provide alternative conditioning therapies for transplant patients with significant comorbidities. So just to wrap up as a whole, over the past 20 years, considerable experience has been gained using reduced intensity conditioning regimens for allogeneic transplant. And although a number of different regimens have been tested, one unifying feature is that they have the potential for acceptable rates of donor engraftment and lower triplet-related mortality relative to conventional or dose-intensive myeloablative conditioning. Because most children tolerate conventional dose-intensive conditioning and TRM increases with age, reduced intensity conditioning has mainly been reserved for older patients or those with poor performance status. As such, multiple studies have been published demonstrating benefits of reduced intensity conditioning in the adult population. However, most of the studies are non-randomized and meaningful comparisons cannot be performed due to multiple factors. What's even worse, or what's even harder, is that the reduced intensity conditioning transplants experienced in children and adolescents is even more scant, more sparse. And most of the studies are single institution experience with small heterogeneous groups of patients with variable conditioning regimens and immunosuppressive therapy and short follow-up. So one fundamental difference between reduced intensity and myeloablative conditioning is the mechanism of disease control. With myeloablative conditioning, relapse protection is provided by dose-intensive chemotherapy and or radiation therapy, and the allogeneic graft-versus leukemia effect. In contrast, the lower dose of chemotherapy and radiation therapy associated with reduced intensity conditioning may provide little upfront disease control, and thus the efficacy of reduced intensity conditioning has been ascribed to the post-transplant graft-versus leukemia effect. Now, how we can harness the GVL effect while minimizing toxicities, but without exposing the patient to graft-versus-host disease, is an exciting area of research currently, and one in which I hope we have an answer over the next few years. So trying to separate that GVHD and GVL so we can try to get the benefits without the risks of GVH. So this completes my talk. I just want to extend some thanks again to Noel and the chief residents for inviting me to speak today. So I want to give a shout out to everyone in our division. I don't want to name people, I'm sure I'm going to forget someone. I also want to say thank you to our inpatient and outpatient medical nursing and support staff, and really especially to all of our patients, families, and everybody who supports them. So thank you very much.
Thank you, Randy, for such a fantastic talk and taking us through the journey of transplant through the years, and most recently with your work here. It's really truly remarkable, and it's useful to review and appreciate all that goes into that. We have several questions here. The first from Dr. Dermody. Randy, thanks for the thorough review. I learned a lot. What do you think accounts for increased risk of VOD in RIC protocols, and how would you prophylax against it?
Thank you, Dr. Dermody, for the question. It's a very good question. So I think at least in our protocol here, I believe the increased risk of VOD was primarily seen in more the myeloablative arm, and probably attributed to the busulfan that we use. Although we didn't really push the dose too high, and we actually, even though it's myeloablative, we would consider it reduced toxicity, we were still seeing a fair amount of VOD. We fortunately weren't seeing as much VOD in our reduced intensity conditioning. Those we did see it were relapse patients who were more heavily treated. So prophylaxis that we've used would be really more aggressive fluid restriction and diuresis, as well as defibrotide in those we consider higher risk. And even though defibrotide is only FDA approved for treatment of severe VOD, we've been using it off-label for prophylaxis. The European community uses it pretty extensively for both prophylaxis and treatment, and it's undergoing study in the US, but I think we'll probably get FDA approval hopefully within the next year or two.
Thanks. I want to make a comment too, that you were just totally stealth through the obvious construction going on inside your office there, and your bobblehead and your likeness stayed upright the whole time, which was fantastic.
Thank you.
We have a question. Any prospect of conducting this study with other institutions?
Thank you for the question. I think that would be great. We will hopefully be wrapping up our study within the next year or two, and I think if our data hold up, I think it might be worth presenting to one of our international conferences, and also really trying to do this on a multi-center, multi-institutional trial through the CWMTR and through the TCT, or transplantation and cellular therapy community.
Thank you. Dr. Choi asks, thank you for the amazing work you are doing. As we become a multiracial society, is it harder to find bone marrow matches for these patients?
Yes, absolutely. And this is why, really, a huge reason why we try to encourage not only looking for blood donors, but also bone marrow donors in minority patients. So anytime that when someone can donate blood, they can also join the bone marrow registry as well. And in order to accommodate our multiracial patients, we can only really do this with multiracial donors. So I think really we're encouraging everyone to join these registries and make themselves available for these life-saving treatments, not just for pediatrics, but also for adults as well.
If you could briefly comment, what's the general process for the related donor marrows and timeframes? And
for our related donors, we tend to work them up at the same time as our recipients. Actually, it's a fairly quick turnaround time with them once we know that they are a complete match. They will undergo some additional testing just to make sure that they're safe and adequate candidates to be bone marrow donors. And then if deemed so, they undergo a bone marrow harvest in our operating room here. For the most part, it's a fairly quick procedure. I think most kids we can get done within an hour's time. And after the bone marrow is collected, it'll go down to our stem cell lab, require any processing that might be needed, and then come up to the patient's room for same-day infusion.
Great. We have a question. Thank you for a great talk. Can you please comment on whether reduced intensity conditioning might have decreased late effects compared to myeloablative conditioning?
Great question, and absolutely yes. This is one of the big reasons, big pushes to using reduced intensity conditioning. We're able to reduce both the short-term and long-term side effects of these very toxic treatments. So by minimizing the chemotherapy, and you can even use radiation at a reduced intensity level, we're able to decrease the rates of long-term organ dysfunction, secondary malignancies, infertility, and really a whole slew of long-term effects that we see more so in the myeloablative population.
Thank you. I think we've answered all the questions. Let me just check the chat to make sure there are any there. I guess Erica posted the donor link in the chat, which is fantastic. Thank you. And we have a couple comments. Very promising, excellent overall outcome on our institutional protocol. So congratulations on that. Well, we will switch over. Thank you again for sharing your expertise with us. And for any who would like to join on our meet and greet, there's a link in the chat, and we will see you there in a few minutes. Thank you.
Thanks so much.